So approach to vertigo, it's very tougher to understand, but you should definitely understand because it's an important high yielding topic. Okay. So as I have already told you, we are having three bony labyrinths: cochlea, vestibule, semicircular canal. The membranous labyrinth within the cochlea is called cochlear duct. The membranous labyrinth within the article is called vestibule is called article cycle. Within the semicircular canal is called semicircular canal duct. Now we are having separate epithelium for linear balance, separate epithelium for angular balance. Okay. So what are the epithelium? We are having macula. This macula is situated over the atricle. It is for horizontal linear balance or horizontal linear acceleration. The macula over the saccule is meant for vertical linear acceleration. Very, very, very important. Which is for horizontal, which is for vertical, they will ask. The crista ampliaris present over the semicircular canal has no role separately. It is completely for angular acceleration. It is completely for angular acceleration. Okay, fine. So, how the vertigo can happen? Vertigo can happen due to three. So, abnormal head movements can cause vertigo. So, you are going in a bus, sudden stoppage of bus. You're going in a lift, sudden stoppage of lift. You're going in a roller coaster. You're getting out. So, these are all normal physiological vertigo and nystagmus. All of us will experience. But without abnormal head movements, without a roller coaster, right? Normal position itself, the patient is getting vertigo. Now, that is called positional vertigo caused by BPPV. Positional vertigo caused by BPPV. Or I have already told you, you could see the lateral semicircular canal through the medial wall of the middle ear. So, with that note, if the cholesteatoma could erode the lateral semicircular canal by cholesteatoma, it could also cause abnormal vestibular stimulus. Okay, these are the conditions in which vertigo stimulus is created without the actual necessity. Okay, fine. Bony defect. If that is superior semicircular canal dehiscence syndrome, okay, this also can be tested with a few diagnostic tests. Okay, so these are not normal vestibular stimulus. These are abnormal vestibular stimulus that is creating vertigo and nystagmus for the patient. Creating vertigo and nystagmus for the patient. Okay, fine. So what are the diseases? I have told you: BPPV, cholesteatoma, and then superior semicircular dehiscence syndrome. Now, how we are going to test the vestibular stimulus? By caloric test. Fitzgerald-Halpike bithermal caloric test is the first test. So when you inject cold water, opposite side nystagmus. When you inject warm water, same side irrigation. Same side nystagmus. COWS. Okay. So you should remember it as just COWS. Okay. Cold water, opposite side. Warm water, same side. Okay. These are the features of caloric test. Now, I am suspecting a positional vertigo. How can you confirm it? See, it is very, very easy and important. See, look into it. If the patient is having a diagnostic test, it is Dix-Halpike test. To do a Dix-Halpike test, you diagnose BPPV. Whereas you have to do therapy for this patient. So this patient therapy is Epley's maneuver. Therapy for this patient is Epley's maneuver. Okay. The first test, caloric test, has been done and dusted. Second one is fistula test. So we are going to introduce cecal speculum into the air. It will pump the air. So whether the pumping of the air is creating some vertigo nystagmus or not, we are going to watch. Okay. Pumping of air first into the ear canal, then into the TM. No change has been seen. If some change has been seen, it could be these diseases, which is false positive fistula. No fistula, but it gives vertigo nystagmus. It is venous disease, congenital syphilis, superior semicircular canal dehiscence. When you ask this question, very, very important. False positive fistula is called as Henneberg sign. Okay, Henneberg sign. Fine. Or the patient has been, if the labyrinth has been completely affected and has become a dead labyrinth, then also it will create a false negative fistula. Fistula is there, but we can't test for fistula because the entire labyrinth has been dead, so we are not able to test anything. So it is false negative fistula in dead labyrinth. So this is completion of vestibular stimulus and test for vestibular stimulus. How can you look into the vestibular response? Okay, so either vestibulo-ocular reflex can be found out by or tested by saccades and pursuits, and then video and electronystagmography. Okay. Right. So what is saccades? See, you're looking into this class, suddenly your mama brings some samosa in front of the screen. Your eyeballs will slowly look into the samosa like this. Your eyeballs will slowly look into the samosa like this. Slow pursuit of your eyeballs into the moving object is called pursuit. Now you're getting into mind that I'm having my FMG exam 20 of this month. I have to get back to business. So immediately eyeballs coming back to straight position. So slow pursuit to laterally, coming back to straight position, fast movement. So saccades are called fast movement. Pursuit or slow movement. Saccades are fast movement, pursuit or slow movement. It can be diagnosed with video and electronystagmography. So if I am going to test a vestibulocerebellar pathway, which has also been infected or involved, you could do Rombox test, finger nose test, adiadobuconesia, ataxicate. This you could read better in medicine. I have just mentioned the names. Okay. Next important thing is WEMP. In WEMP, they are having two types. One is ocular WEMP, second one is cervical WEMP. Okay. Ocular WEMP tests superior vestibular nerve. Cervical WEMP will be testing inferior vestibular nerve. Ocular WEMP will be superior vestibular nerve. Cervical WEMP will be inferior vestibular nerve. Very much important. This WEMP is an important diagnostic test of choice for superior semicircular canal dehiscence syndrome. Now, the difference between central nystagmus and peripheral nystagmus. Central nystagmus is very easy to understand. It will be gradual onset, longer duration, direction changing, very important, associated with CNS symptoms, no suppression with gaze fixation, non-fatigable, exactly opposite. So a sudden, short duration, fatigable, horizontal torsional type of nystagmus are all features of peripheral nystagmus, whereas central nystagmus will be very difficult. Okay, the patient will find very difficult to survive. So we are having some test called Hints test. Hints test is done for bedside stroke assessment. Patient stroke can be assessed with this test. So if it is head impulse positive, it is peripheral nystagmus. See, you remember it very easily. Head impulse, HI for head impulse. Head impulse positive, peripheral nystagmus. Nystagmus is direction you leave it. Test for squamous positive, central nystagmus. That's all. So head impulse positive, peripheral. Test of squamous positive, central. That's how you should differentiate between central and peripheral nystagmus with Hints test. Okay, fine. So now we enter into the most common benign tumor of middle ear. So now the tumor can arise from two main areas. One is jugular bulb over the floor of the middle ear. Another one is tympanic plexus over the medial wall of the middle ear. Okay, one is jugular bulb from the floor of the middle ear. Another one is tympanic plexus from the medial wall of the middle ear. So both will spread into the middle ear mastoid cavity and will cause, if at all, it will cause conductive hearing loss. Conductive hearing loss. Okay, or bleeding from the ears. So importantly, more than the symptoms, signs are very much needed to understood in this one. Okay, fine. What are the signs? Okay, so if you see a vascular mass arising from the floor of the middle ear, it is like a sun coming out of the sea. Okay, so rising sun sign, very, very important. Second one is blanching of redness on increasing pressure more than systemic pressure. Okay, so we are just applying pressure into the ear. If the tumor blanches on applying pressure, it is aqueous sign. If the tumor pulsate on applying pressure, it is pulsation sign or brown sign. Okay, erosion of bony canal between jugular vein and carotid artery is called as Phelps sign. It's called as Phelps sign. Okay. The treatment for this patient is surgical excision. Surgical excision. Right. We come to almost halfway mark. We have completed around 27 pages. We'll have few other pages. Okay. So my speed is okay, or I need to increase my speed. Okay. With this speed, I could complete in another 1.5 hours. Okay, I will complete it. Is the speed okay, ma? Dr. Gaurav? Speed is okay, or I need to increase a bit? Because you will be busily studying. The days are very nearing. I need to go like this, or I need to increase the speed. Please give me some answers, at least for this. Hello? All good? Okay. Okay, with that, but let us have some 5 minutes break. Okay. So I'm taking for around 2 hours. I have a 5 minutes break. You also have a 5 minutes break and come back. Just be with me. And I will be sharing this PDF for you. Okay, it will hardly 70 pages. Could have a quick revision of this. Okay. So vestibular schwannoma. So it's like we saw, glomus tumor is the most common middle ear tumor. Vestibular schwannoma is the most common inner ear tumor, which is again benign. Okay, it's a benign inner ear tumor arising from Schwann cells of the vestibular nerve. So there will be progressive sensory hearing loss, which is unilateral. That is very important. Okay. So progressive sensory hearing loss, which is unilateral. Tinnitus will be there. Vertigo will be there. And the most important thing is there will be anesthesia over posterior superior canal of the external auditory canal. It is called Hitzelberger sign. So this is due to seventh nerve involvement. It's due to seventh nerve involvement. Okay, fine. And there will be cerebellar signs positive. There will be cerebellar signs positive. See, it's a tumor which is affecting the nearby structures. It is originating from the vestibular division of 8th nerve, but it's affecting the cochlear branch, trigeminal branch, cerebellum, and also 7th nerve. So all these nerves are getting affected. These are the features of vestibular schwannoma. So for confirming the diagnosis, I'm going to take a CT scan, CT brain or CT double bone. It will be like this. So I could see the contrast enhanced appearance of the tumor. Now I'm going to take histopathology from the tumor side. That histopathology is going to give me two types of pattern. The pattern number 1 is antennae A pattern, where there will be densely packed cells with small spindle-shaped nuclei. Number 1. Number 2, loosely arranged cells, vacuolated pleomorphic cells. Loosely arranged, vacuolated and pleomorphic cells. Okay. The treatment is very important. I am going to 1.5 centimeter lesser. If the tumor is lesser, you just do follow up for the patient. You don't have to treat. As it is a benign tumor, it is not going to do much harm for the patient. Okay. 1.5 to 2.5 centimeter, I am going to do a stereotactic radiosurgery or stereoradiotherapy. I am going to give radiotherapy that will not affect the surrounding structures. Number 3, if it is more than 2.5 centimeter, I am going to do a surgery. Okay. The surgery is a cranial surgery. Anyways, I'm going to open the cranium. I'm going to do the surgery. Okay. So this is the treatment options available for vestibular schwannoma, which is the most common inner ear tumor. Okay. The important thing, every year they are asking one question from facial nerve. So concerning the FMGE ENT part, facial nerve is very important. Okay. We'll start with some important one-liners. Facial nerve of Risbrook is the sensory division of facial nerve is called nerve of Risbrook. Facial nerve is a 7th cranial nerve. It's a mixture of both sensory and motor branches. It comes out of the pontomedullary junction. Okay. So then it enters the ear through the internal auditory meatus. Okay. Then from the internal auditory meatus, it has 4 subcourses, okay, namely intracanalicular part, labyrinthine part, geniculate ganglion, tympanic part, and mastoid part. Okay, geniculate ganglion is found between the labyrinthine part and the tympanic part. Okay, clear. So what is very important? See, these measurements are quite important. Intracanalicular 5 to 8 millimeter, labyrinthine 3 to 5 millimeter. But important thing, this labyrinthine part is more prone for injury because it is the narrowest part and also it is not covered by bone. The only sub area or course of that intratemporal fascial nerve which is not covered by bone is labyrinthine portion. Okay, so not covered by bone, so prone for injury, and it is narrowest. Then we are having geniculate ganglion. Okay, from where greater superficial petrosal nerve arises. Very important. Okay, greater superficial petrosal nerve arises from geniculate ganglion. That is very important. Okay, so we are having three branches from the intratemporal course of the patient now. Number one is greater superficial petrosal nerve, that is helpful in lacrimation. Okay, number two is from the tympanic part, no branches arise. The length is 9 to 11 millimeter. Just make a note of it. From the mastoid or vertical part, we are having two branches. One is nerve to stapedius, another one is chorda tympani. Now, both are important. Nerve to stapedius, already I have told you, it supplies the stapedial tendon, which is an important muscle that is attaching to the stapes ossicle. So, with that, stapedial reflex has been done to prevent hyperacusis. Chorda tympani is a sensory nerve which supplies the anterior two-thirds of the tongue for sensation. Extracranial course, it comes out of the stylomastoid foramen. The terminal branches of the nerve are temporal, zygomatic, buccal, marginal mandibular, and cervical. So if the terminal branches are gone, the patient will be having a muscle palsy of the face. Okay, the landmarks. Last exam itself, there was the landmark. So we are having two landmarks: intratemporal landmark, extratemporal landmark. In intratemporal landmark, you look into the picture which I'm talking about. See here, this is the medial wall of the middle ear. So we're having medial wall of the middle ear. Give me a second. So this medial wall is again crashing. I don't know why. Okay. So let me tell you again this. So cochlea. Crashing. So we'll see some other time. So just look at this. So we are having medial wall of the middle ear like this. We'll be having promontory like this. We're having oval window. We're having round window. The facial nerve runs like this. Okay. So we're having process cochlear formations like this. So now look into this. This facial nerve, yellow color thing, is posterior superior to oval round window, point number 1. It is superior to process cochlear formation, point number 2. Okay, it is behind the pyramid. Pyramid is lying somewhere over here. Behind the pyramid, which is over the posterior wall, number 3. Number 4, it is inferior to the semicircular canal. The lateral semicircular canal will be over here. See people, they are having medial wall of the middle ear, which is common for the inner ear. The inner ear structures of facial nerve, promontory, lateral semicircular, all will be forming important landmarks on the medial wall of the middle ear. These landmarks will be having relationship between each other. This facial nerve is having important landmarks for identifying the facial nerve during surgery. If we don't identify this, we may injure the facial nerve during ear surgeries. For these reasons, landmarks for the facial nerves are very important. Okay. So first one, the only area which is above the facial nerve, that is lateral semicircular canal. So the relationship is inferior to lateral semicircular is the relationship. For all other things, it could be either posterior or posterior superior, and from it behind is the facial nerve. So extra temporal branches, they're having a relationship just tragus or Conley's pointers. You just palpate the tragus of your ears, just 1.5 centimeter anterior and inferior to the tragus, you will be having an extra temporal first landmark. Then second landmark is 8 millimeter deep to the tympanomastoid suture line. Third landmark, lateral to the styloid process. Fourth landmark, superior to posterior belly of digastric. So these are the landmarks of extra temporal course of facial nerve. Okay. So this is a question from the 2018 FMGE. Which of the following is used as landmark of facial nerve in the parotid gland surgery? So parotid gland surgery. So which is the landmark? Please answer. Please, I want every one of you to answer. Kindly answer. So whoever who are present here, please answer. Dr. Tamil, Dr. Jeevan, Dr. Jayaprakash, please answer. Hello, please answer. It's a previously asked FMG question. You should be answering it. Hello, Dr. Gaurav, please answer. The answer is A. Okay, it's a tragal pointer. Tragal pointer conversation. The posterior border of mylohyoid, I didn't mention. Tip of helix, I didn't mention. Styloid process. So styloid process is not exactly used in parotid gland surgery. It is a landmark, but the best landmark is tragal pointer or Conley's pointer. So this facial nerve, cochlear nerve, and vestibular nerve all will be coming in or going out of the temporal bone to the internal auditory meatus. This internal auditory meatus will form a important landmark called Bill's spot. Okay, the seventh nerve will be above, the cochlear nerve will be below. Example: a bar having a table, 7-up kept above, cochlea coke kept below. So seventh nerve above, cochlear nerve below, and then SPN above, IVN below, superior vestibular nerve above, inferior vestibular nerve below. So this is divided by falciform or transverse crest. Divided by falciform or transverse crest. So above there will be a Bill's bar between the seventh nerve and SPN. There is a Bill's bar between the seventh nerve and SPN. Okay, fine. It's a facial palsy. So we are having two types of facial palsy: supranuclear or UMN type of facial palsy, LMN type of facial palsy. This UMN type of facial palsy is nothing but a supranuclear palsy. So if it is affected, opposite side lower half only affected. Opposite side lower 1/3 only affected. Okay. Whereas in case of Bell's palsy, 1/2 of the face completely affected. The LMN, lower motor neuron type of facial palsy. So in Bell's palsy, what are the clinical features? Will be loss of frowning, loss of nasal labial fold, incomplete closure of eyelids, deviation of angle of mouth. So the important thing is, though Bell's palsy is the most common cause of LMN type of facial palsy, okay, the cause is unknown. Bell's palsy is an idiopathic facial palsy. What is the treatment you are going to give for Bell's palsy? 1 milligram per kilogram steroids, and there's no role for surgery. Okay, Bell's palsy is a very important discussion point. You should always never forget. No role for surgery. You could give steroids. So they have asked question last year also. Which of the following drug will be best to prescribe for facial palsy? So which among the following is a steroid? It is prednisolone. It's a prednisolone. See, this is a question which was asked in this June session. Okay. So they are asking a lot of questions from facial palsy. That one we are entering into nose rhinology. So they ask question right from the starting of the rhinology, which an infant developed difficulty in breathing, which improved on crying. What is the diagnosis? Can someone answer this? Can someone please answer? Hello. Breathing difficulty improved on crying. So it's a typical choanal atresia. Okay. So we first start with choanal atresia. So choanal atresia is nothing but persistence of a bucco-nasal membrane which is found between oral cavity and nasal cavity. A membrane which is found between oral cavity and nasal cavity is called bucco-nasal membrane. If that membrane becomes persistent, it is called a bucco-nasal membrane of Hochstetter. It is a part of a syndrome called charge syndrome. Okay. The main presenting complaint of this patient is difficulty in breathing. So the problem is the child will be a obligate intranasal breather. Okay, child will be a obligate intranasal breather. So the child will not be knowing how to breathe through the mouth. So to make the child breathe through the mouth, they are inserting a nipple called McGovern's nipple. So this McGovern nipple can be used for the child for breathing without stridor or stutter until the surgery has been planned. The surgery best choice is serial dilatations or excision with flap cover. So choanal atresia, this is the endoscopic picture of choanal atresia. The posterior end has been deformed like this. Clear? So this is a CT facial bone axial cut. Can you see the posterior end having a atretic portion? This is a choanal atresia. Right. So this is the oral airway inserted into the mouth of the child. Okay, for choanal atresia. So choanal atresia, it is inserted into the mouth of the child. All right. So we are having few congenital lesions or root of the nose. We just know one point from each. So completely external swelling, it is nasal dermoid. A continuation of brain, it is called nasal encephaloceles. A continuation which was disappeared, it is called nasal glioma. So what? Nasal dermoid is a simple cyst. You don't have to do anything. You remove it. Nasal encephalocele, contact with the brain parenchyma. Furstenberg sign positive. What is Furstenberg? When the child coughs, the swelling increases in size. Okay. When the child coughs, swelling increases in size on child coughing. Okay. Now, as this attachment has been disappeared prior to the birth, this will not have Furstenberg sign positive. This Furstenberg sign negative. So Furstenberg sign positive, encephalocele. Negative, it is glioma. Okay. Then it completes the embryological anatomy of nose. Now let's enter into the anatomy of the nose. The most important anatomy is lateral wall of the nose. Under lateral wall of the nose, we have to understand about osteometric complex. Okay. Under osteometric complex, first we have to understand anterior osteometric complex drains the sinuses such as maxilla, frontal, anterior ethmoidal sinus. Through the form of structure such as hiatus cellularis is nothing but a structure, imaginary space found below the bulla ethmoidalis, and then infundibulum. This infundibulum is found between the ancillary bone and lateral wall. Then ethmoidal bulla is the most constant ethmoidal axis. These they can ask as a one-liner definition. So all of them are important. Hiatus cellularis below bulla. Infundibulum between ancillary and lateral wall. Ethmoidal bulla is a type of air cell. Okay. So these are the structures that are forming the anterior osteometric complex. They are all draining from the middle meatus. Whereas superior meatus will drain from the posterior ethmoidal air sinus. Okay. Posterior ethmoidal air sinus. Inferior meatus will drain from the nasolacrimal duct. So very important. Anything they may ask. They have asked last year. Bulla ethmoidalis drains into which among the following? Please answer. Bulla ethmoidalis drains into which among the following? Kindly answer. Hello, you two. Anyways, you two are going to answer. Dr. Tamil Nesan, Dr. Gaurav. What is the answer, Pa? So, middle meatus. Okay. Answer is middle meatus. Okay, fine. So, this is the last year question. Now, they are going to examine the nose. If I'm examining the nose from the anterior, this is called anterior endoscopy. I'm using a speculum called pudicum nasal speculum. No, I can't see till the posterior end of choana. So I could insert a mirror-like structure through the oral cavity till the nasopharynx. I could see it through a mirror-like arrangement. So this is called posterior rhinoscopy done with Sinclair Thompson post-nasal mirror. So visualize posterior coina all terminates contents of nasopharynx till the soft parallel of pharynx. Okay. So here only till the middle tablet has been visualized, not till the posterior end. So this clinical examination they may ask. Okay, fine. Now the arteries, they have asked a question. I will solve this MCQ and I will tell the treatment for epistaxis. A 42 years female present with bleeding from the nose, the commonest artery that could be the reason for this. This is a last year question. Answer for this question, Dr. Tamil and Dr. Gaurav. Answer is, so sphenopalatine artery is the most common cause of bleeding for this lady. It is called artery of epistaxis. So this sphenopalatine artery and greater palatine artery, all of them are branches of maxillary artery. This anterior artery, posterior artery are all branches of ophthalmic artery. Apart from these arteries, we are having another artery by name superior labial artery. The superior labial artery is a branch of facial artery. This facial artery and maxillary artery are actually coming from external carotid artery ECA. This ophthalmic is coming from internal carotid artery. Any of these can be asked in MCQ. First, you start from ECA, then facial artery separate, maxillary artery separate. Facial artery goes to superior labial artery. Maxillary artery goes to two arteries, sphenopalatine, greater palatine. Okay, so all of them will be supplying. Out of which sphenopalatine artery is the most important one, which is called artery of epistaxis. Okay, fine. Now, anterior artery and posterior artery is called as are branches of ophthalmic artery. Okay, which in turn forms from the internal carotid artery. All right, so this is very important. Now, with this note, we could answer the treatment for epistaxis. First, if the patient comes to you with or calls you for epistaxis, ask the patient to pinch the nostrils. That is called Trotter's method. So, pinch the nose is called Trotter's method. Second thing, being a resident from ENT, you ask the patient to you pack the nose of the patient with roller gauze soaked in bismuth iodoform. Okay, roller gauze soaked in bismuth iodoform. That is called anterior nasal packing. Can you see here? I am inserting and packing the entire nose with the roller gauze. Okay, that is called anterior nasal packing. Bismuth iodoform solution. Then the bleeding is from the posterior end of the nasal cavity due to some posterior femoral artery or anterior femoral artery. So with that, I could not control with the anterior nasal packing. For that, I need posterior nasal packing. The posterior nasal packing is nothing but I'm going to introduce a Foley's catheter. The bulb end I'm going to get inflated, okay, with air or water. So this inflated bulb will hinge over the posterior end of the nasal cavity. This is called posterior nasal packing with Foley's catheter. Okay, so Trotter's method and nasal packing. Now posterior nasal packing. The important surgery of this particular epistaxis is test-pal. What is test-pal? Transnasal endoscopic sphenopalatine artery ligation. Okay, transnasal endoscopic sphenopalatine artery ligation. We are going to ligate the artery with this procedure. No, sir. Though I have ligated the sphenopalatine artery, it's still not yet recovered. Still bleeding is coming from the nose. So we are going to ligate other arteries such as in the order anterior femoral first, then internal maxillary straightly, or external carotid artery as a whole. These are the pattern by which the artery should be ligated in the order if the bleeding has not stopped by the conventional treatment. Okay, fine. So we completed anatomy, we completed bleeding and the epistaxis for the nose. Now entering into diseases of paranasal sinuses. For this, you should be knowing the difference between acute sinusitis and chronic sinusitis. Acute sinusitis less than 12 weeks, chronic sinusitis more than 12 weeks. Very important. Acute sinusitis mainly viruses, chronic sinusitis mainly bacteria, sometimes fungus. That's the major difference. So first you have to know about the development of paranasal sinuses, MESF. You should remember it as MESF. So maxillary sinusitis, you'll be having a cheek tenderness. That's the first sinus to develop, the largest sinus. Okay. Ethmoid sinusitis is over the root of the nose or bridge of the nose. Okay. So the patient secondly develop the paranasal sinus. Third one is frontal sinusitis or occipital headache. Sorry, office headache. Frontal sinusitis or office headache can be causing over the forehead. It will start while going to the office. It will slowly resolve over the evening time. Okay. So MESF, very important. What is the order of development of paranasal sinuses? And then based on location of the pain, how we are going to differentiate various sinusitis. Sphenosinusitis over the occipital. Okay. Right. A lot of potential MCQs are asked from this chapter. Commonest site of obstruction by a nasal polyp of a maxillary sinus. Which could be the commonest site of obstruction? Answer please. So if there is a polyp from the maxillary sinus coming now, which meatus is closer to the maxillary sinus? I've already told you which meatus is closer to the maxillary sinus. Kindly answer, which meatus is closer to the maxillary sinus? See, maxillary sinus means the meatus that is closer is middle meatus only. I told you already, no. See here. So middle meatus only, maxillary, frontal, and rear. Okay, wow. It's a middle meatus. Answer is middle meatus. Fine. Second question. Office headache due to inflammation. 2019 FMGE question. Answer is I told you already. It is office headache is nothing but headache or pain over the forehead. It is frontal headache. Clear? Okay. This one let us discuss. This one I will discuss at the end. I have given you a lot of radiological image. Okay, we'll discuss while discussing the radiological image. Okay, at the end. Okay, so at the end I will tell you. Now, if I don't treat my sinusitis, if I leave it as it is now, what will happen? The most common extracranial complications are orbital complication. Then frontal osteomyelitis is called Pott's puppy tumor. These two are the commonest extracranial complication. If it's an intracranial complication, it could be subdural empyema, meningitis, extradural abscess, or cavernous sinus thrombosis. Okay, so that's cool. These are the complications. Right. So these are bacterial sinusitis. Let me introduce you fungal sinusitis. It's very interesting and very important. Okay, a fungus is infecting the paranasal sinuses. There are two types. One is non-invasive fungus. Another one is invasive fungus. See, this non-invasive fungus is like a small plant is growing over the surface. It is not getting into the soil. Okay, it has no entry into the blood vessels. No entry. Okay. Now let me tell you, fungal balls are nothing but concretions of fungal debris into the maxillary sinus or sphenoidal sinus. Second one, allergic fungal rhinosinusitis. This is given by Bernoulli criteria. Now, these two diseases, if they come now, you should be doing surgery. The surgery name is FES. These two are coming now, you should be doing a surgery. No role for antifungal. Very, very important point. No role for antifungal. Okay, fine. Now look at this. These are invading the blood vessel, angio-invasive. Here, two types are there. Chronic aspergillosis. The most important one is acute invasive fungal sinusitis called as mucormycosis. Very, very, very important. See here, what is happening? There will be spores that is present at the nasal cavity or nasopharynx. If the patient becomes immunocompromised, like uncontrolled diabetes, kidney failure, or if COVID-19, so these kind of conditions will cause the mucor to slowly grow. Okay, slow growth of the mucor causes. It's not a slow growth; it's a rapid growth. Rapid growth of mucor causes rapid erosion of orbit, palate, and even cranial spread. Okay. So if we look at the location, so this is the area of ethmoid sinus. If ethmoid sinus has been involved, it could spread into the orbit, palate, and cranium. So very much critical. It could spread to any of the area. It could be very much detrimental for the patient. It could spread to any of the area. It could very much be detrimental for the patient. Okay. Fine. Surgical management is FES. FES, the steps are uncinectomy. First, we remove the uncinate bone which covers the middle meatus. So, how it is being done? Look at this video. So, this is uncinectomy. See, this is the right side nasal cavity. I'm doing FES surgery. The projected one that you see over there is middle turbinate. This is the uncinate bone which is covering over the middle maxillary sinus ostium, okay, or antrum. This is the process of removing the uncinate bone called as uncinectomy. Removing the uncinate bone called as uncinectomy. Okay, this is how. Once I do that, can you see the canal? And that is the maxillary sinus that I could see. This is the maxillary sinus. Okay, this is how a FES will be performed. So FES, the first step in FES is uncinectomy. Then the middle meatus will be opened for that middle meatal antrostomy. The steps, the order is very, very important and critical. Okay, so then ethmoidectomy, then sphenoidectomy, then frontal recess opening. Then finally, frontal recess opening. Okay. So while doing FS, I may injure an orbit or injure the skull base or injure the optic nerve. These are the injuries I could make. Orbital hemorrhage, CSF leak, or a optic nerve injury. Long-term complications, if I am leaving raw mucosal surfaces, okay, if I'm leaving raw mucosal surfaces, it could lead to synecdoche formation, or long term it could lead to frontoethmoidal mucosal. Okay, fine. Now with that note, we'll solve an MCQ. Yes, 54 years old male present with right side nasal obstruction. On examination, irregular mass present over the lateral wall of the nose. The possible cause could be. Okay, what is the answer? Right side nasal obstruction, 6 months. Examination, irregular mass. What is the irregular mass among these? Any idea? Unilateral nasal obstruction, irregular mass over the lateral wall of the nose. So it could be anteropoinal polyp. Okay, because the anteropoinal polyp is unilateral. It's affecting the adolescents mainly, but in this question not the case. Then it's due to infection. Ethmoidal polyp is bilateral. It affects adults. It's due to allergy. So based on the side, based on the presentation, you could see it as anteropoinal polyp. A rhinos produces not an irregular mass. Okay, it is a grape-like mass. Rhinolic is a brownish stone-like mass. This is also a question asked from last FMGE. Okay, the answer is anteropoinal polyp. So, an ethmoidal polyp, bilateral, adults allergy. Anteropoinal polyp, unilateral, adolescent infection. These 3 points you should never forget. Fine. With that note, we can enter into sinonasal tumors. The carcinoma maxilla is the most common sinonasal tumor. It could happen due to etiology such as softwood, nickel, chromium. The clinical presentation is, if the tumor could go, see this is the position of the maxillary sinus. It's very easy to understand. It could go superiorly to cause proptosis. It could go medially to cause nasal obstruction and epistaxis. Go medially to enter into the nasal cavity and cause nasal obstruction and epistaxis. It could come inferiorly to cause palate erosion. Inferior to cause palate erosion. Okay, fine. Now, looking at the staging, which are all important. The Ongren's line from medial canthus to angle of mandible. The name alone you have to understand. Ongren's line is from medial canthus to angle of mandible. The Liddemann's classification, 2 vertical lines and 2 horizontal lines are drawn. Then T&M staging, best for prognosis and follow-up. Okay. One thing about T&M staging is T3 is involvement of posterior wall. T2, no posterior wall. If you understand this now, you could solve a lot of MCQ. No posterior wall in T2. T3 is posterior wall. Okay. Treatment. Early lesions, you could do surgery alone. Late lesions, surgery plus radiotherapy. Okay. So carcinoma maxilla, they may ask this question by giving the stage or asking for the treatment for this particular clinical scenario. Clear? So another important tumor, which is initially a benign tumor, but later can become malignant, very, very important tumor, inverted papilloma. Okay. This question can be inverted papilloma, okay, if it was given in an option, because it is it very much suits this scenario, suits the inverted papilloma. It is also called as, very important, you just make a note of it, Schneiderian papilloma, Ringer's tumor, transitional cell tumor. Okay, it is common in elderly male. Site is lateral wall of the nose. Cause is human papilloma virus. It is called inverted because it is grown from epithelium into the stroma. See, other tumors will be growing like this, but this tumor will be growing from the epithelium into the stroma. That's why it is called as inverted papilloma. Inverted papilloma, finger-like position, you should remember the other names also, caused by human papilloma virus, very, very, very important. Okay. The patient presents with nasal obstruction, epistaxis. Elderly males more than 50 years are the most common candidate. Lateral wall are affected. Treatment, minimal disease, endoscopic medial maxillary, extensive disease, external approach. You should watch for recurrence because it is highly recurrent tumor. Okay. Another tumor of the nasal cavity is olfactory neuroblastoma or esthesioneuroblastoma. You know very well, olfactory nerves originate from the nasal cavity roof. At the roof, where the olfactory epithelium is present, if a tumor arises, that tumor is named as olfactory neuroblastoma. It can arise from the olfactory epithelium. It can extend and occupy the entire nasal cavity. can extend superiorly and occupy the entire cranial cavity. So arise from olfactory epithelium, can extend and occupy the entire nasal cavity, can extend superiorly and enter the cranial cavity. Presentation is nasal obstruction, epistaxis anosmia. Very easy. Histopathology, small blue tumor cells with rosette formation. Treatment is endoscopic excision. So if you get a tumor at the olfactory area, you should anticipate anosmia mainly. If you go above into the cranium, go below into the nasal cavity, you should do surgical excision as early as possible. Clear? Next one, some of the inflammatory disorders of the nose. Atrophic rhinitis, very important topic. The turbinates are going for atrophy. The lateral wall of the nose has superior turbinate, middle turbinate, inferior turbinate. If these turbinates goes for atrophy, it is called as atrophic rhinitis. It is caused by a bacteria called Klebsiella ozonae. Why it is happening? Chronic invasion by bacteria causes atrophy of the turbinates, and also reduction of size of the turbinates causing roomy nasal cavity due to deficiency of vitamin D and estrogen. Very important. What is the presentation of atrophic rhinitis? First one is greenish crusting, roomy nasal cavity, merciful anosmia, epistaxis. What is merciful anosmia? The patient will be having severe pungent smelling crusting from the nose, but the patient cannot feel his own bad odor. So that is called anosmia with crusting, is called as merciful anosmia. Okay. So you should use nasal douching with chemisetting anti-ozona solution, which is filled with vitamin D, estradiol, and chloramphenicol. These three are the components of the DDC solution. Okay, you should use DDC, which is for nasal douching of the patient. That could be beneficial for the patient. Surgical management. Okay, you should do a surgical management where you could close the nostril of the patient. If you close the nostril, there will not be any air entry. If there is no entry for the patient, no air entry for the bacteria will not thrive. That will lead to death of the bacteria. So we could either close the nostrils one by one or both at the same time. If we close one nostril followed by another, it is called Young's procedure. Okay, complete closure. Whereas if we close both the nostrils with a small gap for breathing, it is called a modified Young's procedure. You don't have to again open the nose of the patient in two sittings. One sitting is enough for this patient. So modified Young's is commonly done for the patient. Clear? So if a child comes to you with foreign body nose like this, it will be unilateral foul smelling discharge, and most importantly, you could anticipate epistaxis. Unilateral foul smelling discharge with epistaxis is an important reason for epistaxis. Okay, that should be removed immediately. For example, if a 14-year child, without knowing, a stone has entered the nose, they have forgotten the foreign body. A long forgotten foreign body undergo chronic inflammation causing granuloma formation is called as rhinolith. Okay, this is a case of rhinolith. See, can you see the blackish chronic lesion around the foreign body? So in this case, there will be invasion of the tissues also. You should do a surgical excision as early as possible. Okay, fine. Next is maggots. Maggots means pulu. Okay, so maggots inside the nose. When the maggots can be inside the nose due to unhygienic nose. Most commonly, it is together with atrophic rhinitis. Most commonly, it is together with atrophic rhinitis. So, maggots are nothing but larval forms of houseflies. See, the houseflies that we see every day, if the nose is unhygienic, it can come over there and lay eggs. The species name is Chrysomia. Okay, what will happen? This eggs will hatch and will become larval forms. This is the larval forms. Can you see? This is the larval form. So this larval form will be present inside the nose and it will eat all the tissues and will cause a lot of nuisance. In that patient, you should be using halothane or turpentine oil. Halothane or turpentine oil. Okay, fine. Rhinosporidiosis. See, rhinosporidiosis, atrophic rhinitis caused by a bacteria. But this rhinosporidiosis is caused by an organism. It is a protozoa. It's an aquatic protistan protozoa. It's an aquatic protista protozoa. So the etiology and mode of transmission is, see, this spores of this particular parasite is present in the cow dung. So when the cows come to the pond water, the cow dung will be laid over there. In the cow dung, which is carrying the spores, can enter into the nasal cavity of the swimmers. The swimmers can be a young kid or adult, whoever who baths in that dirty pond water can get this disease. Okay, so a protozoa which has been transmitted by a cow dung is called as Rhinosporidium seaberi infestation causing rhinosporidiosis. It is aquatic protista protozoa. Okay, I am getting this infection. What shall be the presentation? It is a reddish nasal mass studded with spores. Okay, there could be nasal obstruction and there could be epistaxis. Almost all the nasal lesions you could see nasal obstruction, epistaxis. There is no brainer. Okay, but here comes the important part. You could give medical management of dapsone for 50 milligram and surgery. Very important. You should do excision, cauterization of the base. If you don't cauterize the base, that will lead to spread of the spores from one area to another. So to avoid that happening, you should cauterize the base. Okay, you should cauterize the base. Fine. Next disease, we have completed rhinosporidiosis. The second disease is rhinoscleroma. Rhinosporidiosis is caused by a protozoa. Rhinoscleroma is caused by a bacteria. The bacteria name of rhinoscleroma is Klebsiella rhinoscleromatis, otherwise called as fish bacillus. So 3 stages are there. Stage number 1 is atrophic, which resembles atrabilitis, very easy. Stage 2 is granulomatous, which is subdermal infiltration of granuloma, which resembles Hebra nose. Stage 3 is cicatrial, which is stenosis of the nasal cavity, called as tapir nose. Stenosis of nasal cavity called as tapir nose. Important histopathology, they may ask in the question, very, very important. It will be having Miculic cells and Russell bodies. Miculic cells and Russell bodies. Treatment for the patient is streptomycin and rifampicin. Clear? Fine. Next disease topic is deviated nasal septum. Presentation will be nasal obstruction, compensatory inferior abdominal hypertrophy, or Slutter's neuralgia. See, the nose has been deviated, that part is obstructed. Okay. Opposite part, due to overusage, will go for compensatory inferior abdominal hypertrophy. That will also cause bilateral nasal obstruction. The third one is, if the middle turbinate is constantly pressing over the nasal septal spur, it will cause contact point headache called Slutter's neuralgia or anterior ethmoidal neuralgia. Fine. I've got a nasal obstruction. The patient desperately needs a surgery. What surgery I could advise for the patient? First, I could advise for a septoplasty if the age is less than 17 years, or I could advise for a submucous resection of septum if the age is more than 17 years. Okay, septoplasty for less than 17 years because the cartilage would not have formed completely. Septoplasty is a conservative procedure where we are not removing the entire cartilage, but SMR should be preferred only for age more than 17 years. Okay, patient who is having cartilage growth completed by 17 years can undergo submucous resection, complete removal of cartilage. Here, only removal of the deviated portion and scoring out of cartilage is done in septoplasty. Okay, so the complication is, though we are removing as much, it could be recurrent deviation. Whereas if we remove too much in a SMR, submucous resection septum, that will cause a nasal deformity called saddle nose deformity. Okay, fine. Other important septal diseases are septal abscess and septal hematoma. Okay, involvement of only one side can affect the other side also. There is no role for only one side getting septal abscess or septal hematoma. See here, in this picture, we could see involvement of both sides of the nasal septum. Always both the sides are affected. One side is affected, other side not affected. Is not the case for both septal abscess as well as septal hematoma. Okay, so in this case, you ask the patient to undergo incision and drainage as early as possible. If not, it will erode and cause necrosis of the nasal cartilage. That will be a pathetic case for the patient. Clear? Now, we are having few diseases which could affect the nasal septal cartilage. One is purely cartilage erosion. Second one is bone erosion. Diseases causing only cartilage erosion is trauma, iatrogenic, infection like leprosy and TB. Diseases causing only bone erosion is tertiary syphilis. Okay, both cartilage and bone erosion happens in vaginoscleral metastasis. These are all one-liner points you should have complete go through. Okay, you should have grabbing of all these points. They may ask any of these points. See, they have asked 2 questions over the last 4 years. Syphilis affects which part of